Bismillahirrahmanirrahim. Today we will study the reactive and tumorous lesions of the neural and vascular lesions. So let's start. The learning objectives for today's lecture are to study about the clinical, histological, differential diagnosis and the treatment of neurofibroma, then the vascular lesions such as hamartoma, hemangioma, lymphangioma, angiosarcoma and Kaposi sarcoma. So neurofibroma. Neurofibroma is actually the benign proliferation of perineural fibroblast. They usually appear as solitary lesions in the oral cavity and neck. There is a syndrome which is known as the von Reckling-Hausen syndrome, in which a patient may present with multiple neurofibromas. So frequently these lesions are present on the tongue, buccal mucosa and lips and skin in the form of well-demarcated nodule. Whenever these lesions are present in the bone or in the mandible, these are known as the central neurofibroma and they will produce the unilocular or multilocular radiolucency. These central neurofibromas may be associated with root divergence or bone expansion, but usually no pain and paresthesia is associated with these neurofibromas. So there is another autosomal dominant disorder, which is neurofibromatosis. It has the multiple or several subtypes, and the classification of these subtypes depends on the character, multiplicity, and the skin pigmentation. In single patient, a number of the neurofibromas may range from several to hundreds. In oral cavity, in case of neurofibromatosis, these lesions will present as the soft tissue enlargements. And in some patients, these neurofibromas will become grossly enlarged and may cover the entire extremity. The presence of macular cafe-lot pigmentation of the skin, which is caused by the focal increase in melanin synthesis, as you can see here, these are the cafe-lot pigmentation present on the skin. The repeated surgeries at trying to remove the neurofibroma in case of the neurofibromatosis may predispose these patients to neurogenic sarcoma. So it is very risky to try to remove these neurofibromas in neurofibromatosis patient. So this is the picture of a patient with having multiple macular cafe-lot pigmented lesions on trunk. And in this picture, you can see multiple neurofibromas producing the elephantiasis look, and the lesions have grown grossly in size and leaving the patient's structure totally disfigured. So this is a radiographic picture of the neurofibromatosis, the neurofibromatous lesion in the case of the neurofibromatosis. So here you can see, as shown by the arrow, that the mental foramina area, it has become widened. And this is due to the involvement of the neurovascular bundles. On histopathology, if you see on low part, there are spindle-shaped cells with intervening collagen fibers. These darkly stained bodies, these are the cells, spindle-shaped cells, and the light pink background, these are the running collagen fibers. If you see on the high part, the cells are usually benign with the normal nuclei, and their NC ratio is not disturbed, and in the background delicate multiple collagen fibers are running. In differential diagnosis, neurofibroma can be confused with traumatic neuroma, palisaded encapsulated neuroma, leiomyoma, and schwannoma. The treatment for problematic lesions is usually done by the way of surgery. However, in some areas, you can use chemotherapy and radiotherapy, especially for the cancerous lesion in case of the neurofibromatosis. So now let's study about the vascular tissue lesions. Vascular tissue proliferations may be either soft tissues or they can arise within the bone. Within the soft tissues, these are usually the reactive granulation tissue, which occurs in response to any injury, for example, pyogenic granuloma. We will study this in a while. Then comes the hemangiomas, lymphangiomas, and within the bone, the vascular proliferations occur in the form of AV anastomosis that manifest early in life. Now, starting with the pyogenic granuloma, this is a hyperplasia, hyperplastic lesion of the vascular tissue. So, actually, this is the proliferation of fibrovascular tissue which occurs in response to injury. As the name indicates, some people might confuse it with that it might be related to bacteria, but due to the name pyogenic. But it's not the case. It's just the misnomer. So please keep this thing in mind. These lesions are usually seen on the fingers, toes, and in oral cavity. The gingiva are the most frequently occurring site. The oral lesions are usually occurring in the interdental papilla. As you can see here, the lesion arise and appear brightly red in color. However, these lesions are frequently ulcerated. These types of lesions are commonly seen in pregnant ladies where they are known as pregnancy tumors. And in pregnant ladies, this is thought to be due to derangement of some hormone levels. These lesions, the etiology is said to be that these are totally unrelated to gingival and periodontal infection. On histopathology, the granulation tissue is composed of the numerous anastomosing vascular channels. If you see on a lower part, this is a multinodular lesions. These are the multiple nodules. And if you go on high power, you will see that these clear spaces, these are the vessels which are engorged with these red bodies, which are the RBCs or erythrocytes. So the nodules of the endothelial cells, these small cells outside these vascular spaces are the endothelial cells, and they form the aggregates. So these are actually the aggregates of endothelial cells. And here you can see these occur in the medullary pattern. The surrounding stroma is usually loose and fibrous, and mostly it is infiltrated by inflammatory cells. So here you can see this is the gross appearance of the pyogenic granuloma on the gums. And if you see here, this is the microscopic picture. You can see the lesions are in the form of nodule, and they occur as a lobular arrangement of the capillaries, small sized blood vessels. The lesion is the overlying epithelium is lined by the stratified squamous epithelium. The differential diagnosis for the pyogenic granuloma includes granulation tissue, peripheral giant cell granuloma, peripheral ossifying fibroma, hemangioma, Kaposi sarcoma, and bacillary angiomatosis. Now coming towards the hamartomas and neoplasms of vascular tissues. So in hamartomas, there comes the hemangioma and lymphangioma, and in neoplasm, there is a list of angiosarcoma and Kaposi sarcoma, which is a very important topic, and we will discuss in today's lecture. So starting with the hemangioma. What is hemangioma? Hemangioma is actually the proliferation of small and large sized blood vessels. These lesions are commonly seen in children and infants. They appear as birth marks on the skin. They grow slowly as a flat or raised lesion. And most of these lesions involute by puberty. In adults, these reactive venous dilatations occur, which are named as the varix, and these varix are common on the lips and oral mucosa. So sometimes you can see on the backside of the tongue, as you can see here, these are the nodular pigmented lesions. These are varices which are present in the adults. These hemangiomatous lesions are commonly seen in children as reddish bluish purple lesion. Usually they are raised or multilobulated, and they blanch on compression. Whenever these hemangiomas occur within the muscles, they involve the soft tissues of the head and neck, and tongue and lips. Whenever you palpate these lesions, they will feel spongy on palpation, and they may distort the surrounding tissue. Here you can see a baby with a hemangiomatous lesion. This is a macule type of lesion involving the half side of his face. So port wine stain is another type of hemangioma which is present on one side of the face, and usually this type of hemangioma follows the division of the one nerve. Like you can see in this picture, this hemangioma, it followed the divisions of the trigeminal nerve. So that is why it is only localized to this area. These hemangiomas usually appear as the reddish macule which are sharply demarcated. There is a syndrome known as the Sturge-Weber syndrome, which is also known as the encephalotrigeminal angiomatosis. In this syndrome, there is a unilateral port wine stain along with intracranial hemangiomas. And on radiography, you will see the tram-line calcification, and the patients might present with epilepsy and the mental retardation. So this is in the radiographic picture of a Sturge-Weber, of a patient suffering from the Sturge-Weber angiomatosis. You can see here, these are the tram-line gyriform calcifications in the occipital lesions. Now coming towards the AV malformation, which is again a type of the hemangiomas. These are actually the soft and hard tissue. They occur in the soft and hard tissues of the head and neck, and they appear as painless, slowly growing, and brood and auscultation is produced. The teeth in surrounding area of this malformation, they are usually compressible with spongy sensation, and the gingival area affected with these malformations will have the will show hemorrhage, spontaneous hemorrhage. Arterial pressure will fill the large bore needle without even pulling the plunger, so you can imagine how much blood will be present around in these malformation. Whenever these radiography is done on, they will produce radiolucency, which will appear just like the wormholes in wood. That is due to the tortuous course of the vessels. So here you can see this is the normal structure. This is the artery, this is the vein, and they are connected by the by small sized capillaries. And here you can see the capillaries have vanished, and there is a direct connection between the arteries and veins. So those hemangiomas that arise within the bone, they cause, they are known as the central hemangioma. They cause the bone expansion, and on radiography, they will produce multilocular radiolucency, but these lesions will not associated with any brood. On histopathology, the hemangioma will show that there are multiple small and large dilated vascular spaces which are filled with the erythrocytes. There are two types of the hemangiomas. One is the capillary and the cavernous. So the capillary indicates that these in this type of hemangioma there will be small size of blood vessel, and in cavernous there will be larger size and dilated blood vessels. So in capillary hemangioma there will be focal aggregates of the endothelial cells, plump endothelial cells, just outlying these vascular spaces. The capillary hemangiomas basically resemble the pyogenic granuloma, except that the former lacks the inflammatory cell. So in case of the cavernous hemangioma, we can see that there are irregularly large dilated endothelial lined channels that are engorged with the RBCs, and the intervening stroma is fibrous. However, in case of the large vessel, there will be no muscular core. In case of the port wine hemangiomas, they will have the same shape and histopathology just like that of the capillary hemangioma. And in case of the AV malformation, it is not possible to get the biopsy. And minimal provocation for biopsy can be fatal, as it can lead to release of the large amount of the blood that can be fatal for the patient. Usually, these malformation lesions, they are diagnosed with the imaging studies such as the Doppler angiography, contrast time lapse angiography. So these are the histopathological picture of the cavernous hemangiomas. These are the large vascular spaces engorged with the erythrocytes. Here you can see on the higher part, these are hemosiderin deposits, and these are the large spaces. And this in the center of these large spaces, these are the erythrocytes. So the central AV malformation will have the large size blood vessels with their muscular and adventition walls. So you can see here with their muscular coats. These vessels, they replaces and they press the bone. That is why they will replace the bone marrow, and the surrounding bony trabeculae will show the resorption. Differential diagnosis of the hemangioma includes congenital hemangioma, port wine stain, which is also known as the nevus flammeus. Students, this port wine stain is very important from your examination point of view. You can get this question both in the MCQs as well as in SEQs. And the pyogenic granuloma, again, this is very important. And for in differential for hemangioma, there is a infantile hemangiopericytoma, Kaposiform hemangioendothelioma, tufted angioma, and Kaposi sarcoma comes under the heading for differential diagnosis. So coming towards the lymphangioma. Lymphangioma is actually the benign proliferation of lymphatic vessels, and these type of lymphangiomas are usually seen in the childhood. The head and neck lesions are usually self-limiting. Whenever these lesions and these lymphangiomas occur in the neck lesion, these are known as the cystic hygroma. As you can see here in this picture, this baby has neck swelling, prostically enlarged neck swelling. This is known as the cystic hygroma. When you palpate these lesions, they will be soft and fluctuant masses. The oral lymphangiomas are usually seen on the tongue and lips of the children, and either they may persist or they usually involute at the puberty. On tongue, they will appear just like the grape-like clusters with yellowish, and they will feel very soft on the dorsal side of the tongue. In case of the cystic hygroma, these are usually the pedunculous swellings in the neck, just as shown here in this picture. On palpation, they are cystic and fluctuant. However, the surgical removal of lymphangioma in babies, it is very problematic. So lymphangiomas are on histopathology. They are actually the thin wall dilated vessels which are lined by the plump endothelial cells, and the lumen is filled with proteinaceous fluid. In cystic hygroma, there are large dilated channels that extend deep into connective tissue, and they may traverse the muscle fibers. These lesions are usually infiltrative in nature, but usually they do not cause any type of destruction. The positive marker for lymphatic lineage are the D240, VE, GFR3. So these are the markers for the lymphatic vessels. So this is the histopathological picture. You can see here, these are the large dilated vessel, and within these vessels there is a pinkish proteinaceous fluid. Here you can see this is the epithelium. Underlying the epithelium there are multiple dilated spaces. The differential diagnosis of lymphangioma includes the cellulitis, AV malformation, cheilitis granulomatosa, dermoid cyst, infantile hemangioma, lingual thyroid, lymphangioma, mucocele, and granula. This is just to gain your attention. I hope you are listening. So now starting with the angiosarcoma. Angiosarcoma, as the name indicates, this is a malignant tumor. This is a sarcoma, right? This is a malignant tumor of the vessels. This malignant tumor may arise from the endothelial cell either of the blood or the lymphatic. So this means it can arise from either from the blood or the lymphatic vessels. These angiosarcomatous lesions are common in children as well as in young adults. The the oral lesions of angiosarcoma are usually encountered in Kaposi sarcoma, and this Kaposi sarcoma is usually seen in association with the HIV infection. The immunomarkers for angiosarcoma are the CD31 and ERG. So here you can see in this picture that this is the clinical picture of angiosarcomatous lesion present on the skin as ulcerated, crusted, and pigmented lesion. And if you see on microscopy, you will see that this is a highly cellular lesion with multiple irregular vascular spaces. These clear spaces, these all are the vascular spaces, and they are lined by atypical endothelial cells. These atypical endothelial cells will have the disturb NC ratio, pleomorphism, and cytological atypia. They may show the multi-layering instead of single layer of the lining epithelia. And in some cases, these spaces, vascular spaces, may contain RBCs. There is you will see the brisk mitotic activity. This means you will find a lot of mitotic figures, and the necrosis. Usually, you should remember that the sarcomatous or the carcinomatous lesion, they have a feature of a disturbed NC ratio. In addition to that, they will have the brisk mitotic activity as well as necrosis. So now coming towards the Kaposi sarcoma. So this is again a malignant tumor of the blood vessels, as the name indicates. This is actually, it is said to be a unique type of the angiosarcoma, and these lesions are specifically associated with HIV infected individual. The lesions are usually seen on lower extremities, and in case of the head and neck area, the palate is the most commonly affected site. The causative agent for Kaposi sarcoma is said to be HHV8, human herpes virus number 8, or Kaposi sarcoma herpes virus, right? The risk group for Kaposi sarcoma include homosexuals, the IV drug users, and the infected females. They can transmit the infection or the transmit to their babies. So the Kaposi sarcoma in HIV positive individual are usually the diagnostic criteria for AIDS. The immunomarker for this Kaposi sarcoma include factor VIII related antigen and CD31 and CD34. Here you can see this is the Kaposi sarcomatous lesions present on the skin. See how pigmented nodular these lesions are. And this is the CD31 stain, which is staining the vascular lining spaces. The Kaposi sarcoma lesion usually appear as the flat, macular, and purplish plaque, and they can later on evolve into nodules, reddish nodules. In case of the oral cavity lesions, they appear as soft. They appear both on the soft as well as hard palate, as you can see here in this picture. And you may see some lesion on the facial gingiva. When these lesions are blunt, there will be no compression. This is due to the lack of the vascular channels. This means that this lesion is so highly cellular that there are no immature or mature vascular spaces. This whole lesion is so cellular. So this is the histopathological picture of Kaposi sarcoma. See how cellular this lesion is. This in the form of the nodule just underneath this keratinized stratified squamous epithelium. Kaposi sarcoma on histopathology may present if as a plaque stage, or there is another, the nodular stage. In the plaque stage, you may see that there are the slit-like vascular spaces. small slit-like spaces with the beaded configuration. Here you can see of the endothelial. This is the beaded configuration of endothelial cell around the lumen. So this is the PAT stage in which shows the newly formed blood vessels. This is the high power photomicrograph, and these are all the newly formed blood vessels. So these are the proliferating endothelial cells which form a nodule type. This nodule is then protruding into already formed blood vessel, and this is actually the promontory sign for the Kaposi sarcoma. In nodular stage is actually the hypercellular stage, and two types of cells are present. One is the spindle shaped cells, the elongated. These are the spindle shaped cells and with a pleomorphic nuclei, and another one are the endothelial cells which usually surround the slit like spaces. However, in case of Kaposi sarcoma, mitotic figures are not that apparent and relatively mild cytological atypia. Despite that this is sarcoma, but you may not find mitotic figures and cytological atypia in, as compared to if you compare this lesion with the last one, angiosarcoma we just studied. And on high power, you may see that these red bodies, these are actually the extravasated RBCs, and in some lesion you may find hemosiderin throughout the lesion. So this is the actually nodular Kaposi sarcoma. This is the photomicrograph. You can see here these all are the spindle shaped lesions with a high NC ratio, hyperchromatic nuclei, and the small spaces, white spaces, these are actually the slit like small spaces. And here you can see this is the CD34 marker that has used for marking the Kaposi sarcoma. The treatment for Kaposi sarcoma includes both surgery, cryotherapy, and radiotherapy. That's all for today. Thank you very much.